My name is Tammie Ballie-Stanton. I am working currently at Rahima Musa Hospital. I work in the emergency department and I'm a specialist emergency physician with a critical care background because I've just been doing my critical care fellowship. When it comes to ventilation, I think a lot of us can feel very confused and not necessarily sure what to do. So I've just taken it back a step to make things even more simple than my previous talk. Just kind of some of the simple concepts that I think we need to grasp before you actually start looking at ventilating a patient. Okay, so with regards to ventilation, you kind of have to think about what are my main aims? What do I want to achieve by ventilating this patient? I want to get oxygen in, I want to get carbon dioxide out, and I want to rest the muscles, the respiratory muscles, so that I can decrease my work of breathing, all to assist the patient. So they might be ventilated for pneumonia, a patient might be ventilated for lung disease, for example, ARDS, a patient might be ventilated perioperatively around the time of theatre, a patient might be ventilated or chosen to be intubated to protect the airway. There's a number of reasons why somebody might be intubated and ventilated, but the main aims specifically for ventilation are for the movement of oxygen into the cells, CO2 to be moved out of the cells and out of the body, and to rest the muscles. So when we're talking about ventilation, you guys have had a number of talks from various people looking at non-invasive ventilation, or NIV, as one of the methods of ventilation. CPAP, so continuous positive airway pressure, might also be a method of non-invasive ventilation, especially if you've got a CPAP machine or a CPAP device, like what they often have in neonatal ICUs, but also in some emergency departments and obviously respiratory wards and ICUs. Other methods of oxygenating a patient has also already been discussed. For example, the high flow nasal cannula, which is very popular and gaining popularity, especially with COVID illness as well. But what we're going to be talking about today is really just the basics of invasive positive pressure ventilation. Bearing in mind that the IPPV, invasive positive pressure ventilation, is not a natural phenomenon. We naturally breathe by negative pressure ventilation, that's spontaneous breathing. So there's a whole bunch of mechanics that we need to consider, and there's a number of hemodynamic changes that can happen when you decide to invasively ventilate a patient. So one of the things that you need to think about is, when I'm setting the ventilator, how do I set it? You need to have a look at, is it an adult or a child? Because most modern ventilators have got specific modes for children and for adults, and you look for the setting to make sure that you set it correctly. You also need to have a look at, am I ventilating a male or female, and have a look at the weight. So do I look at actual body weight? And if you look at this low dox here, it clearly shows that we've got a very large obese patient, probably morbidly obese. But if you actually look at the size of the lungs, you'll see that the patient has got normal sized lungs despite the increased adiposity. And if you were to use the actual body weight of this patient, which is close on 160 kilograms, and if you were to set the ventilator for 160 kilograms, you would find that you could probably damage the lungs and cause pressure and volume complications by over-ventilating the patient if you were to choose the actual body weight. So it is preferred that we have a look at the ideal body weight, and that's only attainable by measuring the height of the patient. So have a look at the length of the patient if you've got a measuring tape, and then what you can do is you can either calculate all the very difficult formulae for ideal body weight that if you know them off by heart, or if you're just a regular run-of-the-mill doctor, you're going to use MedCalc to calculate their ideal body weight. And then you're going to ventilate the patient according to their ideal body weight, rather than popping the lungs and causing ventilator-induced lung injury to somebody by over-ventilating them based on their body weight. So a measuring tape is also probably required. Okay, so when you're also ventilating a patient, we've got two major concepts that we need to look at. One is oxygenation and one is ventilation. When we're talking about oxygenation, we're talking about actual delivery of oxygen from the outside of the patient into the alveoli, but we're also wanting to determine the amount of oxygen that is available or it can be supplied on a cellular level to aid with cellular respiration. So it's delivery of oxygen to tissues is what we're most interested in. And you can't really look at that specifically on the ventilator, but it's the outcome, and one of the things that we want to achieve is oxygenation. When we talk about ventilation, most people refer to ventilation as the act of ventilating a patient. So sticking them on a ventilator, so having an ET tube in place and doing invasive positive pressure ventilation. But when we're looking at the physiological principles behind a ventilation, it's important to consider that actually the breathing, inspiration and expiration, inhalation and exhalation, is the movement of air in and out of the lungs. But ventilation, specifically when we're talking about patients that require mechanical ventilation or assisted oxygen therapies, we're talking about the CO2 and the CO2 clearance. So how do I assess oxygenation of the patient? Well, there's two methods, and the one I seem to have deleted, sorry about that. The first one of assessing oxygenation is to look at pulse oximetry. So although we can look at how a patient is coping by looking at cyanosis and looking at signs of respiratory distress clinically, if we're looking for an objective measure, we can look at pulse oximetry, bearing in mind that pulse oximetry does have problems. For example, if a patient is cold, underperfused, if there's hemoglobin issues, if you've got a low hemoglobin, or you've got a hemoglobinopathy. So abnormal hemoglobins can also cause problems if somebody's wearing nail polish. If they are peripherally shut down, for example, significantly shocked, our pulse oximetry might not be that reliable, but it is a non-invasive tool that is fairly readily available, and we can assess oxygenation with that. In most emergency settings, we would consider a SATs of less than about 92% in Johannesburg as maybe abnormal, less than 94% maybe at the coast as less not normal, but it also depends on the patient. So a patient who's got chronic COPD, chronic lung disease with emphysema, they might happily have SATs of 85%, and they are on a home oxygen delivery device, so they're on home oxygen, and they can probably be happy with SATs of 85. So also looking at an absolute number is not the best practice. You need to look at what is the appropriate number for a patient. For example, little kiddies with bronchiolitis might have SATs of 88, but they could be happy wheezers, and it isn't necessarily to be something to be too worried about. If you've got somebody who is hypoxemic, and that is when you've done a blood gas. Now, blood gas is actually even better than doing pulse oximetry, because it's going to give you a value of the pressure of oxygen in the blood. So we're looking at a PaO2. And if you're looking at a hypoxemic patient, it's going to be less than normal, and normal is usually considered about 80 millimeters of mercury. Less than 60, we would call the patient significantly hypoxemic, and they would have a type 1 respiratory failure. And so a hypoxemic patient is a patient that is requiring oxygen, whether you do the gas before to determine the level of oxygen in the blood, or once you've intubated your patient, you need to assess your oxygenation as well. You need to see if your therapy, the ventilatory strategy that you've chosen, is effective at improving oxygenation. How do I assess ventilation? If you have got a capnography, so end-tidal CO2 device, or just a capnometer, depending on where you're working. If you're lucky enough to have capnography, it can give you a clue as to the ventilation as well. So if the end-tidal CO2s are high, that's pointing towards hypoperfusion. If the end-tidal CO2s are hypoventilation, if the end-tidal CO2s are low, it can also point towards hyperventilation. So you're probably hyperventilating the patient with regards to your ventilation strategy. Just bear in mind, though, that end-tidal CO2 also comes with some provisos, and it is probably one of the best tools to assess perfusion of a patient. So if a patient is hypoperfusing and is got a very low blood pressure and isn't perfusing their cells and their organs, the end-tidal CO2 also might be low. And you, as a practitioner, might see an end-tidal CO2 that is low and you think, oh dear, I'm hyperventilating my patient. But actually the blood pressure is really, really low, and that's why the end-tidal CO2 is low. Much the same as if your SATs are very, very low, it might be that the patient is not oxygenating well, but it also might be related to that you're not perfusing the patient well. So that's why the SATs reading can be low. So although this is a nice tool, it's also not without problems. And it can also lead you down the wrong path as well. So again, when we're trying to assess ventilation, we're trying to assess the PaCO2. So the partial pressure of carbon dioxide in your blood. So the usual measures of PaCO2 would be somewhere around about 30, 35, 40, 45, depending on the patient and the circumstances. And pretty much the same with end-tidal CO2, we would probably aim for 35 to 45 with a normal of about 40. So PaCO2 is the most objective measurement of assessing our ventilation. So if the CO2 is normal, but the PO2 is low, so less than 60, but the PaCO2 is normal, that is a type 1 respiratory failure. And that patient needs attention to oxygenation. A patient who has got a high PCO2 has got respiratory failure as well. And if the patient is hypoxemic with the partial pressure of oxygen less than 60, and a high PaCO2, for example, above 55 to 60, that patient is hyperventilating probably because they're really tired and their respiratory muscles are tired. So doing a blood gas is the best way to assess the effectiveness of your ventilation. So how are some of the ways that we can improve our oxygenation? So when you're ventilating a patient and you do a gas, or you look at the SATs and you see the SATs are low, it's always a good idea to clinically examine your patient. We're going to go through the dopes mnemonic for somebody that's deteriorating in front of you just now. But if your patient is stable and there's good breath sounds and you're sure that the ET tube is satisfactorily secured and the blood pressure is good, what are some of the ways that we can adjust the ventilator to improve oxygenation? So FiO2, so that's the fraction of oxygen delivered, or the percentage of oxygen that we're delivering to the patient, is one of the ways that you can increase oxygenation. So if the patient is only on 40% oxygen when you find them, you could up the FiO2 while the SATs are low all the way to 100, while we're stabilizing the patient and trying to figure out what else is going on. Other methods with regards to ventilation is to increase the mean alveolar pressure. And by doing this, this increases the amount of time for oxygenation at an alveolar level and cellular level. So by increasing the ways that we can do this is to increase the PEEP of the patient. So most people think that a PEEP of 5 is normal. And I'd like to say in a hypoxic patient, a PEEP of 10 is probably a really good place to start. It's not high, regardless of what you might have learned at medical school. So I'd recommend popping the patient on a PEEP of 10. That's the bare minimum as far as I'm concerned. But if your patient is already on a PEEP of 10 and you've already upped the FiO2, consider going up with your PEEP, because that's one of the ways to recruit the patient. So alveolar recruitment, although we're not talking about recruitment procedures, it does mean that the alveoli pop open and they don't collapse with each tidal ventilation. So increasing PEEP is one of the ways to maintain recruitment of a patient. The best way to select what PEEP you need for the patient is to look at a PEEP table from the ards.net. So there's a high PEEP and a low PEEP table, and probably looking at the patient in front of you, you're going to select which range of PEEP I'm going to choose. So you'll find very often the recommendations, if you're on a really, really high level of oxygen, a FiO2 that's particularly high, and I'm not managing to oxygenate the patient might need a much higher PEEP, even all the way up to 24. How do I assess or change my ventilation? So minute ventilation is defined as the respiratory rate times by the tidal volume. Now we've looked at tidal volume that you want to start ventilating somebody on when you have just tubed them. It's probably not a bad idea to choose 7 to 8 mils per kg. However, as quickly as possible within the first hour, you need to bring down the tidal volume to 6 mils per kg within the first hour, based on how the patient is doing and based on gases and what their ventilation looks like and how you're assessing it. So with regards to lung protective ventilation, that's recommended by ards.net, is 4 to 6 mils per kg. And you'll see there's a massive difference between ventilating somebody at 8 mils per kg to 4 mils per kg. Somebody with really poorly compliant lungs with ARDS, where the lungs are wet, heavy, congested, those patients we might ventilate with tiny volumes, the so-called baby lungs. So if you find that a patient, the PaCO2s on the gas are very low, and you think it's due to your respiratory ventilatory strategy, have a look. And it means that you're probably hyperventilating the patient. So your two methods could be to decrease your respiratory rate for somebody that's hyperventilating, or take your tidal volume down. So if you'd started your patient, you just tubed them and you put them on a tidal volume of 7 mils per kg to start with, and you find, oh, the PaCO2 is a bit low, great, you can move your respiratory rate down, or you could move your tidal volume down. And I would recommend your first move would probably be moving down with your tidal volume to 6 mils per kg, because we know that's lung protective. If you find that your PaCO2 is very high, so if it's above 55 or 60, what you need to do is have a look at the blood gas first, because if the blood gas is not particularly affected, so if the pH is not abnormal, so we're not seeing a respiratory acidosis, you don't necessarily have to change your ventilatory strategy. This is called permissive hypercapnia. However, if your pH, depending what text you read and who you follow, if your pH is less than 7.25 with a high PaCO2, that is respiratory acidosis, and you do need to adjust your ventilation, because a really high CO2 can have complications, for example, tachycardia and changes in vasculature. So we do need to be concerned about high levels of CO2. So if you find that there is a respiratory acidosis with high levels of CO2, you can increase your respiratory rate. So if you're sitting on a low respiratory rate of about 14, you can take it up and then repeat a gas and see what happens. And if your PaCO2 has normalized. In an adult patient, I would probably recommend of not ventilating faster than a respiratory rate of 25. The other thing that you can do is to also increase your mean alveolar pressure by increasing your tidal volume as well. So you could do this by increasing your pressures if you're using pressure ventilation. Okay, so oxygenation is looking at the PaCO2 or the SATs. You change it by either increasing your FiO2, your PEEP, or decreasing it depending on what you find. And also with oxygenation, when you put somebody on the ventilator, you want to make sure that you bring the FiO2 down to 60 as quickly as possible, as long as the patient is tolerating it, as long as their SATs are okay. As long as the SATs are above 90, you can wean that FiO2. Ventilation is talking about CO2, and we are going to change the PaCO2 because that's the best way to monitor ventilation by adjusting the respiratory rate and the tidal volume. Okay, now most people get really confused when we talk about modes of ventilation. And I touched on this a little bit the previous time. There's controlled modes, and then there's assisted modes. So controlled modes are controlled mandatory ventilation, the very old ventilator modes. For example, in theater, where a patient is paralyzed, and we might need to have the patient is not going to be producing any spontaneous breaths because they are paralyzed for a laparotomy. So we might have a pressure control ventilation or a volume control ventilation. Some of the old transport ventilators also have got these controlled modes. There are also assisted modes, so fully assisted modes or partially assisted modes. And you might see AC, so that's an assist control. So you can have a volume assist control and a pressure assist control mode. Those are the two probably simplest modes, volume assist or pressure assist control. You can also have SIMV, which is pretty much a dual mode. It used to be taught as a weaning mode, but actually a lot of research and literature has shown that it's not a favored mode because it decreases the function of the diaphragms and it can cause prolonged ventilation, and it can also cause diaphragmatic tiring and weakness, which means the patient is on the ventilator for longer. Also, SIMV mode, synchronized intermittent mandatory ventilation, is a very complicated mode to set. The patient might be too tired to generate really good tidal volumes in the spontaneous breaths. So you'll see the ventilator control ventilations have got good tidal volumes, and a patient who's got respiratory muscle fatigue with a pressure supported breaths might be really small with tiny tidal volumes. And this can be rectified by setting the pressure support to an adequate number so that we achieve a good tidal volume. However, it's a complicated mode. My advice is to move across, especially for a newly intubated patient, to a pressure assist control mode or a volume assist control mode, because those are probably the easiest modes. The patient can either spontaneously trigger a breath, and if the patient does trigger a breath, it will be identical to the volume, the controlled mode ventilatory breath as well. There are other modes available that we're not chatting about today because these are the fairly standard modes, the ones that I've spoken about, but there is PRVC. There are also dual mode ventilations, for example, BiPAP. They're the more complicated modes, for example, APRV, so pressure release ventilation. There are also different methods of ventilation. For example, non-conventional ventilation, like high-frequency oscillatory ventilation, but those are also very complicated modes of ventilation. I would highly recommend, if you've put somebody on the ventilator, I would choose a pressure assist control or a volume assist control. Volume assist control is probably the easiest to set because you calculate the volume, the tidal volume that you want, and you put that into the machine. And if the patient is taking a breath, for example, when the muscle relaxant wears off, they will get an assisted breath. And if they are not breathing, they will get a controlled breath. But each breath will be identical, makes it much easier to set. Just a comment about ventilation. I'm sure a lot of you have done some reading with regards to intubation And there's a lot of literature which is looking at the safety of intubation, especially with regards to difficult airways. If you have a patient who has a difficult airway, you shouldn't climb in with a laryngoscope. Unless you're a very skilled practitioner, you should probably call for help. And don't intubate somebody without realizing that there are a number of complications that can occur, especially if you're not a skilled intubator. It's pretty much the same thing with a ventilation. A ventilator can be a weapon of mass destruction if somebody doesn't quite know what they're doing. But I hope that if you find somebody that is on a ventilator, has been already intubated and ventilated, and you've taken over the shift, and now you need to look after somebody, you will at least have a strategy with regards to, okay, I need to do a blood gas on this patient, I need to look at oxygenation, and I need to look at ventilation, and some strategies to adjust the ventilator accordingly. Having a patient on a ventilator does not save a patient's life. A ventilator can be very dangerous in the hands of somebody who doesn't know what they're doing, purely because there's a lot of parameters to set. Patients can complicate very easily. ET tubes can dislodge, they can be bitten, and patients can desaturate very quickly. So having a patient ventilated or an ICU bed means that the patient has to be monitored in an environment with care and support of people who know how to care for an intubated, ventilated patient. So ideally an ICU setting. But I do know that often many patients are on their way to a high care facility or a higher level of care. So we do sometimes have to manage patients that are ventilated and intubated. For the patient that is crashing in front of us, that's intubated, it's just a reminder of the DOPES mnemonic. I'm sure many of you have come across it in your various ALS courses. So if you have a ventilated patient that's intubated and ventilated and they're deteriorating in front of you, so their stats are crashing, maybe their blood pressure is dropping, you need to go through a very rapid assessment of the patient to see what is going on. So the tube might be dislodged or displaced. So you need to check and see where it was at the teeth. If you intubated and the depth of the ET tube was 23 and it's now sitting at 17, you know that it's probably dislodged. Also, if it's sitting at 26, it might be an issue, could also be dislodged as well. You need to look at the oxygenation. So the oxygen supply, is our ventilator actually connected to the wall? Or if I'm bag mask ventilating the patient, is my tubing connected? Is my oxygen cylinder run out? Do I have a PEEP valve attached if I'm BVM ventilating the patient? P, obviously look at the patient, see if I popped a pneumothorax, because patients can have spontaneous pneumothoraces as a complication of proventilatory technique, or they might have had a small pneumothorax from the trauma that they were intubated and ventilated for, and now it's become a tension pneumothorax. The E is also have a look at all of your equipment and make sure that your settings on your ventilator are correct. It is a really good idea to actually take the patient off the ventilator if they have desaturated, put the FiO2 all the way up to 100%, so FiO2 of 1, bag mask ventilate the patient and clinically assess the ET tube. So also suction down the ET tube and see if there's any obstruction. I think I missed out the O. Yeah, I did. Oh gosh, yeah, the O, obstruction. Sorry about that. So the DO is, the O is for obstruction. So the patient might have got a mucus plug or have aspirated and there might be something blocking the ET tube. Or they might be biting violently the ET tube because you've forgotten to give them analgesia and sedation after you've intubated them. And the last one is, so have a look at the stomach. It's a good idea to decompress the stomach, especially in kiddies, but adults too, especially if you've been bag mask ventilating them before intubating them. The stomach is full of fluid or air. It can also obstruct the diaphragm and obstruct the ventilation. So have a good approach to somebody that has desaturated or is decompromising in front of you. So the patient that is doing much worse, who's intubated and ventilated, use the DOPES mnemonic. So displaced, obstructed, pneumothorax, look at your equipment and deflate the stomach. That is the end of my very simple approach to ventilation, rather than looking at the fancy modes and looking at the fancy ventilation graphics. It's really just to look at, okay, so what exactly is this oxygenation and ventilation, and how can I improve it? Okay, I'm going to end my talk there. Do we have any questions?
Perfect. Thanks so much, Tammie. Another great talk and very practical, easy things to remember in a live setting. As just a reminder, you can either raise your hand or type your question up in the chat bar.
If you guys want to ask any questions, please don't be shy to type them in if you're too shy to ask them. Chris and I will have a look at the questions and we'll come up with an answer for you. So I see a question there. Would you go for volume or pressure control as a junior person in ventilation? So I think most of us, when we started ventilation, we usually chose a volume mode. And a lot of studies have proven actually that volume assist control is the most frequently chosen starting mode, because you just need to calculate the tidal volume for the patient. So tidal volume will be based on the patient's ideal body weight. Just remember that. If a patient is fat, obese, they don't have fat lungs. They've still got normal sized lungs. So it's supposed to be based on your ideal body weight. Remember, have a look at MedCalc or any of those. You don't have to remember fancy formulae. And then so their body weight times by, and I would probably start when you ventilate somebody, you just put them on the ventilator, 7 to 8 mils as your starting point, and as quickly as you can come down, come to 6 mils per kg. So let's say that your patient is 50 kilograms. So 50 times by 6, David, help me out, is 300. Is that correct? Yeah, okay, so then you would have, if the patient's ideal body weight was 50, they're a small skinny lady, and she is an appropriate weight for her, then you're looking at 300 mils, a tidal volume of 300 mils per minute. So.
Perfect, thanks, Tammie. I see Ivan has a question. Ivan, I'll unmute you, and then you can unmute you from your side.
A comment, an excellent talk. Comment about rest in the respiratory muscles, which is great when you initiate the ventilation, but prolonged ventilation, and certainly many years ago they used to paralyze the patients in the ICUs. I think is counterproductive. Do you take any note of this with your ventilation? Certainly in my practice, I prefer the patient triggering the ventilator, so volume controlled or pressure controlled, to try and prevent the total non-use of the respiratory muscles. Any comments?
Hi, Ivan. Thank you very much. That's such an important topic. So I agree with you. Back in the bad old days, we used to paralyze patients, and sometimes for a fairly long period of time. And a lot of studies have proven that prolonged paralysis of patients leads to unnecessarily long ICU stays and increased mortality and obviously increased morbidity. For example, ICU acquired weakness or critical weakness. The patient will have decreased diaphragmatic function as well. So lengthy paralysis is not indicated for standard patients. So you would always paralyze a patient when you're ventilating them initially because you've had to intubate them. So part of your RSI or your DSI, whichever you've chosen. And your paralysis hopefully will be long enough to bide you time while you're setting your ventilatory settings. If a patient is able to cope on a pressure assist or a volume assist control mode, they will be able to trigger their own breaths. And that's why these modes are preferred over SIMV, for example. And as soon as a patient is able to be moved across onto a purely assist mode, for example, pressure assist, pressure support modes, a lot of the research has shown that these patients are extubated quicker because they're weaned quicker in ICU. And this actually leads to improved outcomes. So being able to extubate a patient faster, and then they don't have all of the complications of ventilator-associated pneumonia, or ventilator-induced lung injury, or critical illness weakness associated with long-term paralysis. So as soon as you find that your patient's work of breathing has gone down spontaneously, so their spontaneous work of breathing is down, you can wean them onto a pressure support. Bearing in mind that some patients with really severe ARDS or even a refractory status asthmaticus, those patients are a nightmare to ventilate, and you might have to consider paralyzing them up to 48 hours. So there is a trial, a fairly old trial, that looked at the use of cis-atracurium for ARDS patients. And the study looked at a 48-hour period of being on cis-atracurium with actually a good outcome, but for a very select group of patients, and those are the patients with refractory hypoxemia and probably a really high increased work of breathing, so much so that they're actually causing patient-induced lung injury themselves by being so tachypneic. So standardly, no, we don't want to paralyze, but there are a few circumstances where you might consider it. Even for a refractory hypoxemic patient with COVID, you might consider it. As soon as you can get them onto a pressure support mode, you do.
Thank you. A further comment about intubation. Intubation can be, not often, but can be very difficult. A bronchoscope in an experienced bronchoscopist is in fact very easy. But somebody who's never used a bronchoscope will struggle. So I would suggest a laryngeal mask to tide one over until one finds a intensivist who can intubate that patient. You can certainly keep laryngeal mask for quite a long time. Thanks very much.
Thank you, Ivan. I agree with you that we need to be prepared for a difficult intubation. And if you have a difficult airway in front of you, you shouldn't tackle it alone. Always have a backup plan, so an LMA should be available, or a laryngeal tube, so an LT, one of the King Airways. It's my preferred go-to supraglottic airway device. Have simple things available like a bougie, but also have thought about, if I needed to go surgical airway, where would I go? And I think that bronchoscopy is not necessarily an immediate skill available in the emergency department or pre-hospital, although in theatre our anaesthetists are really good, the intensivists or physicians who are frequently doing bronchoscopy, fabulous skill. We're lucky these days because the advent of a video laryngoscope has made difficult airways a little bit easier for us because we have small portable video laryngoscopes that are available in the pre-hospital environment, and many hospitals have got access to a glide scope or a CMAC, even in their emergency departments. So I think it's so good to have a few plans and a few backup skills so that you have a great arsenal when attending to a difficult airway.
Thanks so much, Tammie. I'll do one more round or one more call for questions or comments. And then just while we're giving that some time, as a reminder, I have posted the link on the chat bar. The link will take you to our website where you can see our schedule, our past schedule and our schedule for the upcoming month. We've got talks planned all the way into August. We'll be switching to a twice-a-week schedule from next week. and then tomorrow night will be our last talk for July. The recordings are available there, as well as the registration link as well. So it is kind of convenient. Just go to that page, and I think Mandy's made a comment there, just to listen to this talk in conjunction with the part 1 as well, and they'll go quite well together. But Mandy, before we close off, any other comments from your side? Mandy, are you there?
I'm trying to be here, but my mute doesn't want to unmute. And no, thanks, Chris. I think I just appreciate Tammie coming on again. And I think if you listen to both talks, they'll make a lot more sense. So thank you very much. Appreciate it. And then we are listening to Paul Sandler about the assessment of the COVID positive patient in the emergency department tomorrow evening.
Okay, perfect. Cool. Thanks, Mandy. That sounds great as well. Tammie, thank you once again for giving us your time this evening.
Cool.
I'm sure we'll see you soon.
Okay, bye. Thank you.
Everybody have a good evening.